Assalamu alaikum. Greetings, my dear doctors, and welcome everyone to our Mrcp Part 2 Passmedicine Pal course. And our today's topic would be rheumatology. And let me give you a brief overview on our Passmedicine Pal series course. We should always start our discussion with the Pearl notes, and Pearl notes are the most important components of our Passmedicine Pal series course. And you need to memorize everything. You need to memorize everything from the Pearl notes. And after completing the discussion of the Pearl notes, we will go through the Passmedicine key concepts. And after completing the Passmedicine key concepts, we will take a break. And after the break, we will again resume our second session with Passmedicine textbook discussion. So this is our rheumatology Pearl notes. External rotation on both active and passive movement is classically impaired in adhesive capsulitis, which is also known as the frozen shoulder. And this adhesive capsulitis or frozen shoulder is most commonly seen in the diabetic patient. Usually both external and internal rotation, both of them is impaired, but the external rotation is more commonly affected. And this affection is both in case of active and passive movement. So external rotation is affected more in adhesive capsulitis. So external rotation greater than internal rotation, both in case of active and passive movement. Adhesive capsulitis or frozen shoulder is a clinical diagnosis and doesn't need imaging or arthroscopy to confirm the diagnosis. Choice of treatment is physiotherapy. So in the exam, if they give a typical clinical picture regarding the frozen shoulder and ask what should be the next step, then we don't need to go for any investigation, either imaging or arthroscopy. We can just go for the symptomatic management as well as the physiotherapy. The major target for ANCA is myeloperoxidase, also in short known as the MPO. So can you tell me two conditions where ANCA is most commonly becomes positive? In which condition ANCA becomes positive? In which condition ANCA is most commonly seen to be positive? Anyone? ANCA is most commonly positive in case of GPA, also known as the Wegener's granulomatosis, and ANCA is most commonly positive in case of CSS, also known as the EGPA, also in case of MPA, microscopic polyangiitis. Biopsy, renal, nasal, and skin can be useful in the diagnosis of ANCA-associated vasculitis, that is in case of glomerulonephritis with polyangiitis, also known as the Wegener's granulomatosis. Especially in all the three conditions causing the RPGN, that is GPA, MPA, and anti-GBM, we should go for the biopsy, and the typical biopsy finding should be crescentic GL. But how can we differentiate between the three conditions based on biopsy findings? Anyone? How to differentiate between anti-GBM and GPA based on biopsy findings? In case of Wegener's, we'll get the post-immune crescentic GN, and in case of anti-GBM disease, we'll get the linear IgG deposition with crescentic GN. In a patient with ankylosing spondylitis, the pain is most commonly seen or experienced during the nighttime or bedtime, and AS is predominantly associated with the AV nodal block. What are the other conditions that are associated with ankylosing spondylitis? The role of A, can anyone remember? Anyone? The condition associated with ankylosing spondylitis? Ankylosing spondylitis on pelvic X-ray, the most typical findings is the sacroiliitis, and sacroiliitis is the most common initial radiological findings in case of ankylosing spondylitis. And sacroiliitis, the features of sacroiliitis would be subchondral erosion, sclerosis, and squaring of the lumbar vertebra. So can anyone tell what the squaring of the lumbar vertebra mean, or what the squaring refers to? Why is everyone so calm and quiet? What is the normal structure of anterior border of a vertebral body? Is it concave, convex, or linear? So what is the normal structure of anterior body of the vertebral body? Is it concave, convex, or linear?
Concave.
Yeah, it will be concave. And in case of squaring of the vertebra, what should be the pathological changes? It should become linear. The anterior border of the vertebral body, it will have a pathological change, giving rise to straightening of the ventral section or anterior section of the vertebral body, and the entire vertebral body, it will almost look like a square shape. So the normal vertebral body, it's almost heart shaped and it is rectangular in shape. But in case of squaring of the vertebra, in case of ankylosing spondylitis, it will give rise to the square shape. Syndesmophyte, ossification of the outer fibers of annulus fibrosus are a features of ankylosing spondylitis. So what is annulus fibrosus? Can anyone
These
tell?
are the anterior ligament, I guess, connecting the vertebral column.
So the intervertebral disc, if we divide the intervertebral disc into outer and inner portion, the outer portion is known as the annulus fibrosus, and the inner portion is known as the nucleus pulposus. So let me show you a pictorial. So if we consider this as the intervertebral disc, the outer portion, this is the annulus fibrosus, and the interior portion, the central portion, is known as the nucleus pulposus. And the annulus fibrosus, it may be divided into certain types based on the location, like posterior, anterior, lateral, anterior lateral, and the posterior lateral. And in case of ankylosing spondylitis, mostly the lateral portion, the outer margin and the lateral portion is most commonly affected, which will ultimately give rise to the syndesmophyte. Ankylosing spondylitis, typical appearance of bamboo spine with a single central radiodense line related to ossification of supraspinous and interspinous ligament, which is called the dagger sign. So in advanced ankylosing spondylitis, it will ultimately give rise to the bamboo spine, which will look like a dagger sign. Diagnosis of ankylosing spondylitis can be best supported by sacroiliitis on pelvic X-ray, fusion of bilateral sacroiliac joint consistent with ankylosing spondylitis. So we can get the X-ray findings as subchondral erosion, sclerosis, squaring of the lumbar vertebra, and altogether they are known as the features of sacroiliitis. Loin pain and hematuria in a patient with antiphospholipid antibody syndrome. Think of the renal vein thrombosis. Patients with antiphospholipid syndrome are at a risk of thrombosis, and loin pain with hematuria in hypercoagulable state is most likely a renal vein thrombosis. So if you found loin pain and hematuria in a patient with underlying antiphospholipid antibody syndrome, the diagnosis would be renal vein thrombosis. Next one is the avascular necrosis. So can you tell me two commonest risk factors for AVN?
Steroid and chemotherapy.
Yeah, long-term use of steroid. Long-term use of steroid is the most common cause of the AVN. And the second most common cause is the use of the anti-cancer drug or the anti-neoplastic drugs. So avascular necrosis, this is the aseptic necrosis. Remember, this is not septic or not infective. This is non-infective condition. This will be the aseptic necrosis. This is also known as the osteonecrosis. The collapse of the articular surface resulting in the crescent sign, that is the curvilinear loosened subchondral line, is characteristic of the avascular necrosis of the hip. So it will look like a crescent sign. So radiological changes in case of avascular necrosis of the femoral head: increased bone density, deformity, flattening of the femoral head, osteopenia, and microfracture. The joint space is relatively preserved in avascular necrosis, differentiating this from the osteoarthritis of the hip joint. Usually, osteoarthritis is the only rheumatological condition where the joint space is reduced. In almost all other cases, like whether this is avian or rheumatoid arthritis, all other cases, usually the joint space would remain intact or preserved. So, reduction of the joint space is suggestive of osteoarthritis. And the avascular necrosis should be always investigated with the MRI. Remember, if they ask what is the initial investigation, the answer should never be X-ray. It should be MRI.
Sir,
Yes.
can you please show us how to see vascular necrosis on the MRI, please?
Yeah, I will show you. I will show you when in the second session, when I go through the Passmedicine textbook, I will show you I will show you all the related picture. But right now, I'm just concentrating on the most important lines, and afterwards I will show you everything.
Sir. Okay, thank you, sir.
Azathioprine is metabolized to the active component Mrcp purine, a purine analog that inhibits the purine synthesis. So in case of azathioprine, check the TPMT, thiopurine methyltransferase deficiency before treatment. Azathioprine, mesalazine, and sulfasalazine, all of them are safe to use during pregnancy as well as during the breastfeeding. But remember to give the concomitant administration of folic acid with these drugs. So all these three drugs, they can be given in case of pregnancy as well as breastfeeding. And especially if there is rheumatoid arthritis or ankylosing spondylitis and the patient is pregnant, then usually we start the treatment with azathioprine. Azathioprine and allopurinol have a severe interaction causing the bone marrow suppression, and this will ultimately lead to the pancytopenia. So concomitant administration of azathioprine plus allopurinol will lead to the pancytopenia. Azathioprine is associated with increased risk of non-melanoma skin cancer. And among the skin cancer, the basal cell carcinoma is the most common. So azathioprine is metabolized to the active component Mrcp purine, a purine analog that inhibits the purine synthesis. And check TPMT level before initiating treatment with azathioprine. And azathioprine is safe to use in pregnancy and breastfeeding. Concomitant administration of azathioprine and allopurinol will lead to the bone marrow suppression, leading to pancytopenia, and it also increases the risk of basal cell carcinoma. So Behçet's disease. Behçet's disease is also known as the oculo-oral genital disease, which is more commonly seen in the Mediterranean patient, and usually the age of the patient should be around 20 to 40. They may also come up with the features of a deep vein thrombosis or hypercoagulable state, and the shin lesion is also more commonly seen. And the investigation of choice, the initial investigation can be the Pathology test. So Pathology test means the puncture site following needle prick become inflamed with small pustule formation. And the positive Pathology test is highly suggestive of the Behçet syndrome. Low serum calcium, raised serum phosphate, raised alkaline phosphatase, and raised parathyroid hormone is highly suggestive of chronic kidney disease leading to secondary hyperparathyroidism. So in case of secondary parathyroidism, everything should be elevated except the calcium level, that is hypocalcemia. And in tertiary hyperparathyroidism, there should be hypercalcemia. And always remember, secondary and tertiary hyperparathyroidism can only occur in the presence of renal impairment. If there is no renal impairment, then secondary and tertiary hyperparathyroidism is excluded. And primary hyperparathyroidism will never have the renal impairment. If there is renal impairment, then primary is excluded. Extensive bone remodeling or fragmentation with the presence of a swollen red worm joint with a sensory neuropathy in a patient with history of poorly controlled diabetes is highly suggestive of Charcot's joint or Charcot's neuropathic arthropathy. Usually we'll get the features of sensory neuropathy, but in some cases this may be absent. But this patient will always have the history of diabetes as well as extensive bone remodeling or features of fragmentation. And this may sometimes look like a fracture. So denosumab is the drug used in the management of osteoporosis, especially in the second line or as a third line groups of drug following the bisphosphonate. And it has two commonest adverse effects, dyspnea and diarrhea. So D for D and D. Bisphosphonate and denosumab can be used to prevent pathological fracture in bone metastasis. And when the eGFR is less than 30, then denosumab is preferred. When there is significant renal impairment, then we should avoid bisphosphonate as the first line choice of treatment, and we should switch on directly to the denosumab. And can anyone tell the dose of denosumab? Rule of S, subcutaneous 60 mg, 6 monthly interval. Bisphosphonates and denosumab can be used to prevent pathological fracture in bone metastasis. If the eGFR is less than 30, then denosumab is preferred. So when the eGFR is less than 30 or when the T-score is less than minus 3.5, then we should go for denosumab instead of the bisphosphonate. In a patient with new diagnosis of dermatomyositis, urgent malignancy screen is needed. And dermatomyositis means a presence of photosensitive rash, heliotrope rash, and Gottron's papule. So how to differentiate between the polymyositis and dermatomyositis?
The presence of rash.
Yeah, the presence of dermatological involvement points towards the dermatomyositis. So polymyositis plus dermatological involvement is equal to dermatomyositis. So antibodies present in case of dermatomyositis: ANA, anti-MI2 antibodies, and anti-Jo1 antibodies. And ANA is the most common to be found, and anti-MI2 is most specific. So ANA is most common, anti-MI2 is most specific. Next one is diabetic amyotrophy or proximal diabetic neuropathy. Bilateral proximal myopathy, severe neuropathic pain in thigh, and absence of lumbosacral structural lesion points towards the diabetic amyotrophy and proximal diabetic neuropathy. So the lumbosacral structural lesion should be always absent in this condition. And this is in most of the cases related to uncontrolled diabetes, leading to proximal myopathy and neuropathic pain. And proximal myopathy is most commonly bilateral. Pain is usually is the first symptom of pain in the hips or in the buttocks. The onset of proximal pain as a result of microvascular lumbosacral plexopathy is usually asymmetric before becoming more symmetrical. So microvascular lumbosacral plexopathy, this is usually asymmetrical or unilateral. But diabetic amyotrophy, this won't have these features, and it is usually bilateral and symmetrical. And choice of management should be tight control of the blood sugar and symptomatic treatment for the neuropathic agent. And symptomatic treatment means always start with the pregabalin or gabapentin followed by amitriptyline or duloxetine. Discitis or vertebral osteomyelitis is defined as infection of the vertebral bones with extension into the intervertebral disc. So both bones, bone structure as well as disc should be affected. The clinical presentation of discitis can be variable from acute back pain and fever to slowly progressive back pain over a number of months. An MRI of the spine is the most appropriate investigation to diagnose the infective discitis. And on T2 imaging, we will get the high signal intensity mass. An MRI scan of the spine is the most appropriate investigation to diagnose infective discitis as it has the greatest sensitivity. Discoid lupus erythematosus, this is the dermatological or cutaneous manifestation of the SLE, and DLE is usually characterized by the follicular keratin plaques. And the Schuster sign is most commonly seen to be positive in case of DLE. And Schuster sign means red plaques with adherent scale in concha of the both ears. So can you tell me the initial treatment for DLE?
Stop the drug, I guess.
Yeah, this is the dermatological condition. So we should start with the topical drugs, topical steroid. And if it doesn't respond to topical steroid, then the patient should be treated similar to that of the SLE, that is the oral hydroxychloroquine. And if we go for biopsy, we'll get the interface dermatitis. So DLE is characterized by follicular keratin plaque. First line choice of drug is topical steroid. No response, go for oral hydroxychloroquine. And regarding the alopecia, predominantly we have the two types of alopecia. One is the scarring alopecia, another one is the non-scarring. So scarring means there should be destruction of the hair follicle, and this hair follicle would be preserved in non-scarring alopecia. And usually in the exam, in most of the cases, they give the scarring alopecia. And commonest condition are lichen planus, discoid lupus, that is DLE, and tinea capitis. Tinea capitis in the initial stage, there would be no scarring. But once the duration progresses and no treatment is given, then it will ultimately lead to the scarring alopecia. And commonest cause of the non-scarring alopecia are male pattern baldness, use of drugs like cytotoxic drugs, carbimazole, heparin, oral contraceptive pill, colchicine. Nutritional deficiency like iron and zinc deficiency, autoimmune like alopecia areata, telogen effluvium. Telogen effluvium is the hair loss following the stressful period, like either before the exam or before going for a surgery, and trichotillomania. The drug-induced lupus doesn't cause the glomerulonephritis. Always remember there should be no 2N in case of drug-induced lupus. No neuro involvement and no nephro involvement. If there is neuro or nephro involvement, then drug-induced lupus is excluded. And drug-induced lupus can be caused by a certain number of drugs, and the three most commonest are the isoniazid, procainamide, and the hydralazine. And this drug-induced lupus, this will have the antihistone antibody positivity. So drug-induced lupus will have antihistone antibody positivity, but the anti-dsDNA, it should be typically negative. And Ehlers-Danlos syndrome, it may be either classical or vascular. Classical occurs due to mutation in type 5 collagen, and vascular occurs due to mutation in the type 3 collagen. So which one is more common? Vascular is more common or classical is more common? C5V3, you can remember like this way. So that pattern 3, that is the vascular type 3, V3 is more common. Ehlers-Danlos syndrome is primarily caused by a genetic defect in collagen type 3, that is the V3. Collagen type 5, the classical variant, is less common variant of the Ehlers-Danlos syndrome. And angioid retinal streak, this is the features of the Ehlers-Danlos syndrome. So Ehlers-Danlos syndrome is most commonly associated with defect in type 3 collagen, that is the vascular type. Osteogenesis imperfecta, mutation in the type 1 collagen, and Ehlers-Danlos syndrome, a mutation in the type 5 collagen or the type 3 collagen. So I for 1, imperfecta, abnormality in type 1 collagen. Familial Mediterranean fever, also known as recurrent polycirrhosis, is an autosomal recessive hereditary inflammatory disorder characterized by reoccurring episodes of abdominal pain, fever, arthralgia, chest pain. So this is serositis. So serous layer of the body would be inflamed, giving rise to abdominal pain, chest pain, joint pain, and the fever. Clinical features are pyrexia. Abdominal pain occurs due to peritonitis, inflammation of the peritoneal serous layer, then the pleural layer, pericardial layer, arthritis, and erythropeloid rash on the lower limb. And the choice of treatment is the colchicine. So familial Mediterranean fever is an autosomal recessive hereditary inflammatory disorder characterized by reoccurring episodes of abdominal pain, fever, arthralgia, and the chest pain, and this is known as the recurrent polycirrhosis, and colchicine may be given in case of FMF. Fibromyalgia, the choice of management is to go for the aerobic exercise. Chronic widespread pain associated with lethargy and difficulty concentrating and multiple muscular tender points or associated symptoms of fatigue, non-refreshing sleep, or cognitive dysfunction points towards the fibromyalgia. So this multiple muscular tender point, this is the pathognomonic feature of fibromyalgia. And this is in most of the cases associated with either features of fatigue or some sort of sleep disturbance. The cognitive dysfunction is less commonly seen. Gout X-ray, multiple periarticular erosion bilaterally with adjacent large soft tissue masses and relatively preserved joint space, defined as punched out erosion with sclerotic margin in a juxta-articular distribution. So earliest radiological sign in case of rheumatoid arthritis is juxta-articular osteopenia, ankylosing spondylitis, sacroiliitis, gout punched out lesion, and pseudogout, features of chondrocalcinosis. In case of gout, usually the first MTP joint is most commonly involved. Juxta-articular erosive changes around the first MTP joint with overhanging edge and associated with a moderate soft tissue swelling, and the joint space is maintained. So just remember, the joint space would be reduced in case of osteoarthritis. In almost all other conditions, the joint space is maintained. And rheumatoid arthritis, earliest radiological findings would be periarticular or juxta-articular osteopenia. For gout, if NSAIDs or colchicine are contraindicated or not tolerated, that is due to the CKD, the next option is a steroid. So gout plus CKD, go for the oral steroid, that is the prednisolone. And in case of gout and CKD, for the prophylaxis, we can go for the allopurinol, since the allopurinol is contraindicated in renal impairment. In that case, we should go for the febuxostat. And any degree of cardiovascular disease is a contraindication to go for the febuxostat. So renal impairment, avoid allopurinol. Cardiac abnormalities, avoid febuxostat. And NSAIDs and colchicine, they are also contraindicated in case of renal impairment. One of the notorious side effects of febuxostat is the Stevens-Johnson syndrome. And colchicine is a classical cause of diarrhea, particularly in the elderly and in the higher doses. So colchicine should be avoided in an elderly patient, especially if they have any features suggesting that they might develop diarrhea in the upcoming days. For gout, if NSAIDs and colchicine are contraindicated or not tolerated, the next option is a steroid. Febuxostat can be used in the prevention of gout in patients where allopurinol side effects have been deemed intolerable or the renal function doesn't allow sufficient dose escalation. So predominantly drug causing the gout, the most common are the diuretics and the pyrazinamide. Thiazide, furosemide, cyclosporine, alcohol, cytotoxic agents, and aspirin. Thiazide diuretics can precipitate an attack of gout, and gout has a multiple underlying pathophysiology, but the most common is the decreased renal excretion of the uric acid. And gout means there should be chronic hyperuricemia, and hyperuricemia means the uric acid level should be greater than 450 micromole per liter. Young man, multiple well-defined punched out osteolytic skull lesion with scalloped edge is highly suggestive of the Langerhans histiocytosis. So punched out lesion, it can be seen both in case of gout as well as Langerhans histiocytosis. And especially if the patient is a young patient and the skull lesion is associated with the scalloped edge, then think of the Langerhans histiocytosis. Then we have two types of epicondylitis. One is the lateral epicondylitis, also known as the tennis elbow. Another one is the medial epicondylitis, also known as the golfer's elbow. So in case of tennis elbow, the pain is worse on wrist extension against a resistance with the elbow extended and supination of the forearm with the elbow extended. So the pain is more commonly experienced in lateral epicondylitis when the elbow is extended. And pain on resisted wrist flexion is a sign of medial epicondylitis, also known as the golfer's elbow, which is associated with pain over the medial epicondyle, secondary to a strain of the flexor compartment of the forearm. So tennis elbow or lateral epicondylitis, this occurs due to the elbow extension. So tennis for tension, elbow extension, tennis lateral epicondylitis. And golfers or medial epicondylitis, this is related to the wrist flexion. So you can remember golfers means the girlfriend gifted him a wristwatch. So golfers or medial epicondylitis, this is related to the wrist flexion. So lateral epicondylitis, the pain would be worst on when the elbow is extended. We can experience either with the wrist extension or supination. And pain and tenderness and swelling over the tibial tubercle is highly suggestive of the tibial apophysitis. This is also known as the Osgood-Schlatter's disease. Next one is the mild to moderate pain management in a stepwise fashion. So step one would be to start with the paracetamol, and maximum dose is 1 gram 4 times daily before switching on to or combining to the another analgesic. Step 2 should be substitute the paracetamol with ibuprofen and increase the dose of ibuprofen to a maximum of 2.4 gram daily. Then step 3 is equal to 1 plus 2. So add paracetamol to ibuprofen. And step 4, to continue with paracetamol 1 gram 4 times a day, replace the ibuprofen with an alternative NSAID such as the naproxen. And step 5, start a full therapeutic dose of a weak opioid in addition to full dose paracetamol 1 gram 4 times daily with or without an NSAID. Spinal stenosis is most likely diagnosis in a patient with gradual onset leg and back pain, weakness and numbness, which is brought on by walking with a normal clinical examination. And spinal stenosis is usually bilateral and sciatica is usually unilateral. Osteopetrosis as well as osteoporosis. The laboratory parameters would be normal calcium, phosphate, ALP and parathyroid level. Repeated cramping and myoglobinuria after a short burst of exercise can point towards the Mrcp disease. So patient typically will have muscle pain and stiffness following exercise. muscle cramp, myoglobinuria, low lactate level during exercise. And this McArdle's disease become prominent following exercise. In the normal resting period, usually we can detect the McArdle's disease. McArdle's disease is characteristically associated with the second wind phenomenon and present with distal muscle cramping following exercise. McArdle's disease, also known as the myophosphorylase deficiency or glycogen storage disease 5. So we can have elevated creatine kinase, myoglobinuria, muscle biopsy will show elevated glucose concentration and muscle phosphorylase deficiency, and EMG will show the myotonic discharge and fibrillation. So myotonic discharge and fibrillation is the EMG findings in McArdle's disease. And management should be avoidance of the low carbohydrate diet and low intensity aerobic exercise. Repeated cramping and myoglobinuria after short bouts of exercise can point towards the McArdle's disease. Methotrexate works by inhibiting the dihydrofolate reductase, so MTX is equal to DHFR. Folinic acid is the treatment of choice for methotrexate toxicity or methotrexate-induced myelosuppression. Co-triamoxazole contain trimethoprim and should never be prescribed with MTX. So co-triamoxazole containing the sulfamethoxazole and trimethoprim. And we should always avoid combination of co-triamoxazole with methotrexate. The concurrent use of MTX and trimethoprim containing antibiotic may cause bone marrow suppression and severe or fatal pancytopenia. New oral ulceration on MTX, then we should withhold the MTX initially, and we should go for the symptomatic management for oral ulceration, and following resolution we can again start the MTX. But if there is any features of pancytopenia or any features of aplastic crisis, then we can't use the methotrexate in that patient. MTX can cause hepatotoxicity, so monitor the liver function test. Patients who have started methotrexate should have full blood count, urea and electrolyte, renal and liver function test repeated every 1 to 2 weeks until therapy is stabilized. So folinic acid, this is the treatment of choice for MTX toxicity. And MTX plus trimethoprim concurrent administration will lead to bone marrow suppression leading to pancytopenia. So we should always avoid this combination. Methotrexate may cause hepatotoxicity, so monitor the liver function test. Proximal myopathy along with mechanic hand is highly suggestive of the antisynthesis syndrome. And the NSAIDs can trigger the asthma exacerbation. Next one is the Heber-Dance node, the node on the DIP joint. This is known as the Heber-Dance node, and Heber-Dance node is pathognomonic of the osteoarthritis. The CMC, carpometacarpal, and the DIP, distal interphalangeal joint involvement, is characteristic of the hand osteoarthritis. So in case of osteoarthritis, the CMC and DIP, these joints are most commonly involved. And in case of rheumatoid arthritis, the PIP, proximal interphalangeal joint, and the CMC, carpometacarpal joint, is more commonly involved. Rheumatoid arthritis usually does not involve the DIP joint. If DIP joint is involved, then rheumatoid arthritis is excluded. And involvement of DIP joint typically have 3 differential diagnoses. One is the osteoarthritis, second one is the psoriatic arthritis, third one is the adult onset Still's disease. And osteoarthritis is a degenerative condition. Here we won't get the features of morning stiffness or any features of inflammation. This may occur due to the repetitive use or occupational history related to repetitive use. And the Heber-Dance node is highly suggestive of osteoarthritis. And psoriatic arthritis usually occurs in the younger patient. We will get the features of inflammation or morning stiffness, and we can get features of dactylitis or dermatological involvement or the skin involvement. And adult onset Still's disease, this is the diagnosis of exclusion. So osteoarthritis, first line choice of treatment is usually paracetamol with topical NSAIDs. No response, go for the oral NSAIDs plus PPI coverage. Topical NSAIDs are indicated only for osteoarthritis of the knee or hand. Local muscle strengthening exercise and general aerobic fitness is an important component of knee and hip osteoarthritis. So X-ray changes of osteoarthritis, we can remember using the mnemonic loss. Loss of joint space, osteophyte formation, subchondral sclerosis, subchondral cyst. So LOSS. Osteomalacia will exhibit the Loser's zone. Loser's zone is nothing but also known as the pseudo fracture. It will be exhibited as the translucent band. Old man bone pain with features of tenderness and proximal myopathy, especially in the vegetarian diet takers with waddling gait, is highly suggestive of osteomalacia. And osteomalacia is managed using vitamin D supplementation, often with an initial loading dose regimen. Celiac disease is known to interfere with the absorption of fat-soluble vitamins, including vitamin D and low calcium, and elevated alkaline phosphatase coupled with symptoms of proximal myopathy fits with the diagnosis of osteomalacia. So old man bone pain, not old man. Vegetarian diet taker, bone pain, tenderness, proximal myopathy is highly suggestive of osteomalacia. And old man bone pain with proximal myopathy and isolated raise in ALP, that is highly suggestive of the Behçet disease. So osteomalacia will have low calcium, low phosphate, elevated alkaline phosphatase, and elevated parathyroid level. So vitamin D deficiency versus insufficiency. So when the serum vitamin D level is greater than 50 nanomole per liter, this points towards the adequate vitamin D. We can just recommend the patient to go for the dietary. And when the level is in between 30 to 50, this indicates insufficient vitamin D. We need to go for the maintenance dose vitamin D. And deficient vitamin D when the level is less than 30 nanomole per liter, and we usually need the loading dose of vitamin D in deficient cases. Blood and bone infection caused by non-typhi salmonella are typically associated with malaria and homozygous sickle cell disease, especially in the children. And Staph aureus is the most common cause except in patients with sickle cell anemia where Salmonella species will predominate. So blood and bone infection, especially in case of osteomyelitis, the Staph aureus is the commonest organism. But if the patient has underlying sickle cell anemia, then the answer should be Salmonella species. Obesity isn't a risk factor for osteoporosis. Rather, the lean and thin, low BMI body mass index, this is a risk factor for osteoporosis. Osteoporosis is usually seen in the women of the postmenopausal age group, and this is rarely seen in a male patient. But if osteoporosis is seen in a male patient, think of the testosterone deficiency, so go for measurement of testosterone. T-score, the normal score is greater than -1. From -1 to -2.5 points towards the osteopenia, and if osteopenia is suggestive, then we should immediately start the treatment with calcium and vitamin D. And less than -2.5 points towards the osteoporosis, and we should start the treatment with bisphosphonate provided that there is no contraindication. And when the T-score is less than -3.5, we can go for the denosumab. So T-score less than -1.5, that is any features of osteopenia, go for calcium, vitamin D, and in some cases the bisphosphonate may be needed, especially if the age of the woman is greater or equal to 75 years. and if there is any features of fragility fracture, or if the patient suffers from 1 or 2 fracture despite giving the calcium and vitamin D supplementation. So when to go for the osteoporosis prophylaxis? So prednisolone 75 milligram or other equivalent steroid once a day for 3 consecutive months or more. Start alendronate in a patient greater or equal to 75 years following a fragility fracture without waiting for a DEXA scan. IV bisphosphonate are a second-line treatment for osteoporosis. So we should start with oral bisphosphonate, typically used if there is an intolerance or contraindication to oral bisphosphonate. So what is the commonest side effect of oral bisphosphonate?
Dysphagia.
Yeah, esophagitis and dysphagia. Bisphosphonate treatment failure is defined as 2 or more fracture on treatment or 1 fracture with reduction in the bone density. So how to treat the patient with bisphosphonate treatment failure? Go for the denosumab. Bisphosphonate inhibit the osteoclast. Bisphosphonates are associated with increased risk of atypical stress fracture. Unilateral hearing loss in an old age patient and bone pain with isolated raised in ALP is highly susceptible of the Behçet disease. And Behçet disease will have increased serum and urine level of urinary hydroxyproline. And Behçet disease of the bone, this is also treated with bisphosphonate, that is similar to the first line treatment of osteoporosis. Combination of hearing loss with tinnitus, signs of heart failure, skeletal deformities associated with elevated alkaline phosphatase in the absence of other liver function test abnormalities is consistent with diagnosis of the Behçet disease. And often we can get the skull complication possible due to the cochlear involvement or skull involvement, resulting in hearing loss, high output cardiac failure, and long bone deformities. Serum non-isomerase C telopeptide, that is CTX, is an extremely sensitive marker of increased bone turnover observed in Behçet disease and is useful in monitoring disease progression or treatment efficacy. The skull, spine or pelvis and long bone of lower extremities are most commonly affected in Behçet disease. And on X-ray, we can get the osteolysis in early disease, and we'll get the mixed lytic and sclerotic lesion later on. So at first, we'll get the features of osteolysis, and this mixed lytic or sclerotic lesion, this is highly suggestive of the Behçet disease. And skull X-ray may exhibit thickened vault or calvarium, osteoporosis circumscripta, ill-defined sclerotic and lucent areas. And on bone scintigraphy or scan, we'll get the increased uptake seen focally at the site of active bone lesion. So they will look like the black spot. So first line investigation in case of ankylosing spondylitis, if this is early ankylosing spondylitis, then go for the MRI. But if this is advanced case, the duration is longer, then we can go for the X-ray. This is actually based on the duration. Behçet disease, increased serum and urine level of hydroxyproline, and choice of treatment should be bisphosphonate. Perthes disease is a degenerative condition affecting the hip joint of the children due to avascular necrosis of the femoral head, specifically the femoral epiphysis. Impaired blood supply to the femoral bone causes the bone infarction. So in case of polyarteritis nodosa, usually the ANCA is negative, but the P-ANCA may be positive in some of the condition. And the PAN is most commonly associated with the hepatitis B virus infection. And we can also get the features of mononeuritis multiplex, and mononeuritis multiplex may also be seen in case of CSS. Fever, hypertension, lethargy, neuropathy, testicular pain, renal dysfunction are consistent with the PAN, polyarteritis nodosa. So we'll get features of multiple pain with hypertension, fever, and the renal impairment. And renal angiogram is the diagnosis of is the choice of investigation to confirm the diagnosis of polyarteritis nodosa. And usually the ANCA is classically negative in PAN, but in some cases the p-ANCA may be positive. The PMR, polymyalgia rheumatica, the creatinine kinase and EMG would be normal, and it will follow the ACR criteria of 50/50. Age of the patient should be greater than 50 and the ESI should be greater than 50. Polymyalgia rheumatic is characterized by abrupt onset of bilateral early morning stiffness in over the 60s. Muscle biopsy is the gold standard investigation for the diagnosis of polymyositis. So which antibody is most commonly seen in polymyositis?
Anti-Jovan.
Yes, anti-Jo1 antibody. Anti-Jo1 antibody is most commonly seen in polymyositis. It can also be seen in case of dermatomyositis. Endomysial lymphocytic infiltrate that infiltrate the non-necrotic muscle fiber. This is the biopsy findings of polymyositis. Perimysial inflammation of lymphocyte and parafascicular atrophy, biopsy findings of dermatomyositis. Inflammatory infiltrate and inclusion within muscle fiber, inclusion body, myositis. So patient coming up with features of malignancy plus raised creatinine kinase, no dermatological involvement, think of the polymyositis, and patient should be treated with the prednisolone. Anti-synthetase antibodies are specifically associated with the polymyositis. Idiopathic inflammatory myopathy characterized by symmetrical proximal muscle weakness, elevated skeletal muscle enzyme levels, that is elevation in the creatinine kinase. And muscle biopsy is the gold standard investigation for the diagnosis of polymyositis. So proximal muscle weakness, raised creatinine kinase, no rash, think of polymyositis. Proximal muscle weakness, raised creatinine kinase, features of rash, Gottron's papule. What's the diagnosis? Heliotrope rash. Yes, heliotrope rash, dermatomyositis. Think of the derma. Anti-synthetase antibodies are specifically associated with the polymyositis. Hemochromatosis is a risk factor for Pseudogout. Pseudogout will have the CPPD crystal. And investigation of choice in hemochromatosis is the transferrin saturation. Risk factor for Pseudogout includes hemochromatosis, Wilson's disease, low phosphate, low magnesium, hyperparathyroidism. The PPI may lead to the hypomagnesemia, and hypomagnesemia is a risk factor for Pseudogout. So the PPI may lead to the Pseudogout if there is for a prolonged period of time. And chondrocalcinosis. Chondrocalcinosis is the pathognomonic radiological findings in favor of Pseudogout. And chondrocalcinosis means calcification of the triangular fibrocartilage, and in some cases we can get the double lemniscus or calcification of the medial lemniscus. Hemochromatosis is a risk factor for Pseudogout. Chondrocalcinosis help to distinguish Pseudogout from gout. So Pseudogout, chondrocalcinosis, gout, punched out lesion. Pseudogout will have weakly positive birefringent rhomboid shaped crystal. So P for P, reverse the P, rotating to 180 degree, looks like B. So positive charge, birefringent rhomboid shaped crystal. And in case of gout, what should be the crystal findings? Negative shaped. Yeah, go on.
Needle shape.
Yeah, negative and the needle shaped.
Negatively birefringent needle shape.
Yeah, negatively charged birefringent crystal with needle shaped. Psoriatic arthritis will have extensive juxtaarticular periostitis in the DIP joint, which will ultimately lead to the classic penicillin cup changes. MTX is the DMARD of choice in psoriatic arthritis. Psoriatic arthropathy can present before psoriatic skin lesion. A positive family history of psoriasis may point towards this diagnosis. So Raynaud's disease, usually we can go for the calcium channel blockers or the nifedipine or the IV prostacyclin, that is the epoprostenol. Nifedipine is the first line pharmacological treatment for Raynaud's phenomena. Epoprostenol, amongst other prostaglandin, can be used in the treatment of Raynaud's phenomena. Relapsing polychondritis is a multisystemic condition characterized by which most commonly causing relapsing episodes of auricular chondritis, repeated episodes of inflammation and deterioration of the cartilage. Feltis syndrome. Feltis syndrome means presence of long-standing rheumatoid arthritis with features of splenomegaly and features of neutropenia. Feltis syndrome is a complication of rheumatoid arthritis. It consists of a combination of rheumatoid arthritis, neutropenia, and splenomegaly, and tends to affect the rheumatoid arthritis of the long-standing duration. Feltis syndrome is never seen in the initial stages of rheumatoid arthritis. It can only be seen after prolonged or long-standing duration. The main differential diagnosis of drug-induced marrow aplasia and presence of splenomegaly accounts for the Feltis syndrome. And Feltis syndrome which have the HLA-W4 positivity. Patient with long-standing rheumatoid arthritis has increased chance of the ischemic heart disease and cardiovascular abnormalities. This is the commonest cause of death in patient with rheumatoid arthritis. Rheumatoid arthritis can present with polymyalgic syndrome, that is PMR, prior to clinically detectable synovitis. Anti-CCP antibodies are rarely present in polymyalgia rheumatica but are strongly associated with rheumatoid arthritis. And presence of anti-CCP antibody in rheumatoid arthritis points towards the poor prognosis, and this is also a criteria for the aggressive joint destruction. Rheumatoid factor is a circulating antibody, usually IgM, that reacts with the FC portion of the patient's own IgG. So, recommended guideline for the management of rheumatoid arthritis. So, start with the DMARD monotherapy with or without short course of bridging prednisolone. So, start with MTX with or without prednisolone, and if no response, then the second DMARD may be added. Methotrexate is highly teratogenic and should be stopped between 1 and 3 months before pregnancy. Hydroxychloroquine and sulfasalazine are generally accepted to be DMARDs that can be continued during pregnancy. Sulfasalazine should, however, be avoided in male patients attempting conception due to the risk of oligospermia. So, sulfasalazine causes oligospermia and mesalazine causes the pancreatitis. And the TNF alpha inhibitors, they may cause reactivation of the tuberculosis. What are the TNF alpha inhibitors?
Infliximab,
Infliximab, adalimumab, golimumab, etanercept. Rheumatoid arthritis, poor prognostic features. If you can't remember all of them, you must need to remember the anti-CCP antibody positivity. So rheumatoid factor positive, anti-CCP antibody positive, poor functional status at presentation, early erosion less than 2 years, extra-articular features like presence of nodule, HLA-DR4 positivity, and insidious onset. So white blood cell in the synovial fluid if the count is greater than 1 lakh, then this is highly suggestive of the septic arthritis. And the commonest organism for septic arthritis is Staph aureus. So we should start treatment with IV flucloxacillin 2 gram 4 times daily for 1 to 2 weeks. And depending on the culture and sensitivity, we can change the antibiotics. And if there is no response to IV flucloxacillin, in the second stage, we can go for the IV co-amoxicillin. So septic arthritis, most common organism is the Staphylococcus aureus. Sjogren's patient with Sjogren's syndrome has increased chance of developing the lymphoid malignancy, and usually it is increased by 40 to 60-fold. Salivary gland biopsy or labial gland biopsy is the most definitive way of confirming the diagnosis of the primary Sjogren's syndrome. Sections will show a typical lymphocytic infiltration. Adult onset Still's disease is a diagnosis of exclusion and can only be diagnosed if the rheumatoid fracture and ANA are negative. So RF and AMA should be negative. If they are positive, AOSD is excluded. Adult onset Still's disease is evidenced by fever, characteristic of a rash, salmon pink maculopapular rash with features of arthritis, deranged liver function test, hyperferritinemia, negative testing for ANA and rheumatoid factor. Pyrexia and Still's disease has a characteristic pattern. It typically rises in the late afternoon or early evening in a daily pattern and accompanies a worsening of joint symptoms and rash, and patient will exhibit the extreme hyperferritinemia. That is, the ferritin level should be significantly increased. NSAIDs are the first line treatment for Still's disease, not the steroids. So step 1 or first line is NSAIDs. Second line are addition of steroid. And fourth line may be the DMARD like the Methotrexate, but the definitive management is anakinra or canakinumab, and they are the interleukin-1 inhibitor. Anakinra is more commonly used in adult onset Still's disease, and canakinumab is more commonly used in resistant cases of gout. An adult onset Still's disease can be diagnosed using the Yamaguchi criteria. There are some of the major criteria, some of the minor criteria. So there are 4 major criteria. Fever greater or equal to 39 degrees Celsius, persisting for at least 1 week. Arthralgia or arthritis persisting for at least 2 weeks. Typical rash, salmon pink maculopapular rash. And the WCC count is usually greater than 10 into 10 to the power 9. And the neutrophil, there should be neutrophilic leukocytosis. And usually the neutrophil count should be greater than 80%. And the minor criteria are presence of sore throat, lymphadenopathy with or without splenomegaly, increased serum aminotransferase or lactate dehydrogenase level after other causes have been excluded, negative rheumatoid factor, and ANA in the immunofluorescence assay. Charcot's arthropathy, which is painless, non-erosive, associated with SLE. So SLE induced non-erosive joint pain. Sorry, it is painless. SLE induced non-erosive, painless, symmetrical condition. Think of the Charcot's arthropathy. So it should be non-erosive, painless, and symmetrical. And this is usually associated with the SLE. Lupus nephritis class 4. Class 4 is most common, also known as the DPGN. It carries the worst mortality and the worst renal outcome. And ventricular fibrillation or cardiac arrest, this is a common phenomena seen in a patient with lupus myocarditis. And in those patients, we can continue the amiodarone and treat the patient's underlying lupus. And later on, we should plan for the implantable cardioverter defibrillator. SLE-NA is 99% sensitive and anti-SMIT, and anti-dsDNA are 99% specific. Anti-RNP antibodies can be positive in SLE in nearly 40% of the patient. In which condition anti-RNP antibodies is most commonly seen?
Mixed connective tissue disorder.
Yes, in case of
Disorder.
MCTD. CRP is normal in SLE unless there is a secondary infection. CRP is usually normal in two conditions. One is the SLE, another one is the ulcerative colitis. And they are usually they are only elevated if there is any evidence of secondary flare or secondary infection. Mycophenolate is teratogenic in pregnancy, and hydroxychloroquine, this is the first line choice of treatment for SLE, and this hydroxychloroquine is also safe during pregnancy. So pregnant lady with SLE, we can go for the hydroxychloroquine. SLE in pregnancy, the outcome may be neonatal lupus erythematosus or neonatal congenital heart block. Which antibody is most commonly seen in case of neonatal congenital heart block?
Anti-Ro, anti-La.
Anti-Ro.
So we can have both anti-Ro, and anti-La, but anti-Ro, also known as anti-SSA, this is most commonly seen, and anti-La is less commonly seen, but both of them are associated. Anti-Ro antibodies can cross the placenta, can lead to neonatal lupus and congenital heart block of the newborn, which can require the pacing at birth, and miscarriage is another complication of SLE. The most common cause of death in systemic sclerosis is respiratory involvement, that is interstitial lung disease and pulmonary arterial hypertension. So patient usually die due to the respiratory failure or due to IPF or interstitial lung disease, as well as pulmonary arterial hypertension or primary pulmonary hypertension. Limited systemic sclerosis, that is the central will have the anti-centromere antibody positivity, and the diffuse cutaneous will have the anti-SCL70 positivity. And this is limited cutaneous or central is usually associated with the scleroderma or the features of crest. The most common cause of death in systemic sclerosis is respiratory involvement, interstitial lung disease, and the pulmonary arterial hypertension. Renal complication of systemic sclerosis, what's the name of the condition?
Scleroderma renal crisis.
Yeah, this is known as the SRC, sclerodermic renal crisis. So always treat the patient with AC inhibitors. Scleroderma renal crisis is characterized by malignant hypertension and oligoanuric acute renal failure. Steroid use is known to precipitate scleroderma renal crisis. A renal complication of systemic sclerosis often present with hypertension and AKI. So precipitating factor is high dose steroid, presentation is hypertension and AKI, and treat the patient with AC inhibitor. So usually in case of AKI, we usually avoid the AC inhibitor, but in case of SRC, it should be treated with the AC inhibitor. Jaw claudication is a very specific sign for temporal arteritis, also known as the giant cell arteritis, which may ultimately lead to the arteriotic ischemic optic neuropathy. So choice of treatment, if there is isolated polymyalgia rheumatica, start with the low dose prednisolone, 15 mg, and the highest dose may be either 25 mg or 30 mg. And in case of giant cell arteritis or temporal arteritis, we need to go for the high dose of steroid. So if this is uncomplicated giant cell arteritis or established visual loss, then go for 60 mg prednisolone daily. For complicated GCA, evidenced by transient visual loss, go for IV methylprednisolone 0.5 to 1 gram daily for 3 consecutive days. Methotrexate can be used as a steroid-sparing agent in difficult to control, frequently relapsing giant cell arteritis. Anterior ischemic optic neuropathy results from occlusion of posterior ciliary artery, that is a branch of the ophthalmic artery, which will ultimately lead to the ischemia of the optic nerve head, and on fundoscopy we'll get swollen pale optitis with blurring of the margin. Cervical disc prolapse, this is related to C5 or C6 myelopathy. Granulomatosis with polyangiitis, also known as the Wegener's, this will have the ANCA positivity. Target is the serine proteinase 3, that is the PR3. And microscopic polyangiitis, MP, will have the P-ANCA positivity and target is the MPO myeloperoxidase. So the bone disorder lab fellows, in case of osteoporosis and osteopetrosis, all the lab parameters should be normal calcium phosphate, ALP and parathyroid level. In case of osteomalacia, the ions like the calcium ion and phosphate ion, they should be reduced, but the enzyme and the hormone level would be elevated. Primary hyperparathyroidism means no renal impairment. We'll get the elevated parathyroid level, and parathyroid level is directly proportional to calcium, inversely proportional to phosphate. So increased parathyroid means increased calcium, low phosphate. ALP is also typically seen to be raised. And secondary hyperparathyroidism can only occur in the presence of renal impairment. Also the tertiary. Secondary will have hypocalcemia, tertiary will have hypercalcemia, and everything else should be elevated in both secondary and tertiary. And Passmedicine will have isolated raise in the ALP level. Next one is site of compression and their differentiating points. So typically when we can have either L5 nerve root compression or S1 nerve root compression. Both of them will have the positive sciatic nerve stress test. So sciatic nerve stress test can be used to differentiate between them. S1 nerve root compression will have the reduced ankle reflex, but the reflex will be intact in case of L5. And L5 nerve root compression will lead to sensory loss over the dorsum of the foot and weakness in the foot and big toe dorsiflexion. So amongst the toes, the big toe, the fifth one is this is the biggest. So L5, the fifth, that's mean the largest. This is related to the weakness of the big toe dorsiflexion. And S1 nerve root compression will lead to sensory loss, posterior lateral aspect of leg and lateral aspect of foot, and weakness in the plantar flexion of the foot. So this is our Pearl notes, and once again the reminder, you need to memorize and you need to revise everything from the Pearl notes. You shouldn't skip not even a single line from it. And this key concept, they are actually the copy-paste materials taken from the Passmedicine. A raised CRP in a patient with known SLE may indicate an underlying infection. Adhesive capsulitis is a clinical diagnosis and doesn't require imaging or arthroscopy to confirm the diagnosis. An MRI of the spine is the most appropriate investigation to diagnose infective discitis, as it has the greatest sensitivity. So ankylosing spondylitis, it will have the features. Mnemonic is the S. Apical fibrosis, anterior uveitis, aortic regurgitation, Achilles tendinitis, AV nodal block, amyloidosis. And remember, this is aortic regurgitation. This is not aortic stenosis. So AS is not associated with AS. AS is associated with AR. Anterior ischemic optic neuropathy, fundoscopy typically shows a swollen pale disc and the blurring of the margin. Anti-RNP antibodies can be positive in SLE in nearly 40% of the patient. Anti-synthetase antibodies are specifically associated with polymyositis. Azathioprine and allopurinol have a severe interaction causing the bone marrow suppression. Azathioprine is associated with increased risk of non-melanoma skin cancer, that is the basal cell carcinoma. Biopsy, either renal or nasal or skin, can be useful in the diagnosis of ANCA-associated vasculitis like the GP or MP or anti-GBM disease. Bisphosphonate and denosumab can be used to prevent pathological fracture in bone metastasis. If the eGFR is less than 30, denosumab is preferred. Bone pain, tenderness, proximal myopathy with waddling gait, think of the osteomalacia. Chondrocalcinosis in pseudogout, punched out lesion in gout. And rheumatoid arthritis will have juxta-articular or peri-articular osteopenia. And osteoarthritis will have the reduction in the joint space, subchondral cyst, subchondral sclerosis. And the ankylosing spondylitis will have features of syndesmophyte or sacroiliitis. Cotrimoxazole plus methotrexate, this will cause the fatal bone marrow suppression leading to pancytopenia. Colchicine may be helpful in the familial Mediterranean fever. Denosumab is the ranked ligand inhibitor. Receptor activator of nuclear kappa receptor B inhibitor. Dermatomyositis is commonly a paraneoplastic phenomena, and all patients with dermatomyositis, they should be screened to detect the underlying malignancy. Diagnosis of ankylosing spondylitis can be best supported by sacroiliitis on a pelvic X-ray, Ehlers-Danlos syndrome, and the ARS, angioretinal streakage features. Epoprostenol, among other prostaglandins, can be used in the treatment of Raynaud's phenomenon. Familial Mediterranean fever is an autosomal recessive hereditary inflammatory disorder characterized by reoccurring episode of abdominal pain, fever, arthralgia, and chest pain, which is also known as the recurrent polyserositis. Febuxostat can be used in the prevention of gout in patients where allopurinol side effects have been deemed intolerable or the renal function does not allow sufficient dose escalation. Folinic acid is the treatment of choice for MTX toxicity. For gout, if NSAIDs and colchicine are contraindicated or not tolerated, the next option is steroid. Hydroxychloroquine is the treatment of choice for SLE, lateral epicondylitis. Lateral means the tennis elbow, tennis means tension, extension. Elbow would be extended. Orson rested wrist extension or supination where the elbow is extended. And in case of medial epicondylitis or golfers, the wrist should be flexed. Local muscle strengthening exercise and general aerobic fitness is an important component of knee and hip osteoarthritis. Loin pain, hematuria in antiphospholipid antibody syndrome, think of the renal vein thrombus. Malignancy, raised creatinine kinase, no rash, think of polymyositis. Proximal weakness, with or without malignancy, raised creatinine kinase. Then Gottron's papule, think of the dermatomyositis. Methotrexate can be used as steroid sparing agent in difficult to control, frequently relapsing giant cell arteritis. Methotrexate may cause pneumonitis, typically present with cough, dyspnea, and fever. Muscle biopsy is the gold standard investigation for the diagnosis of polymyositis. Nifedipine is a pharmacological option for Raynaud's phenomenon, and NSAIDs may trigger the asthma exacerbation. NSAIDs are the first-line treatment for adult onset disease, not the steroid. And osteomalacia will have low calcium, low phosphate, elevated alkaline phosphatase. Osteomalacia is managed using the vitamin D supplementation, often with an initial loading dose regimen. Osteoporosis in men, check the testosterone level. Passage disease of the bone is treated with the bisphosphonate. Polymyalgia rheumatic is characterized by abrupt onset of bilateral early morning stiffness in the over 60s. Pseudogout, weakly positively birefringent rhomboid-shaped crystal, and gout will have the negative shape birefringent needle-shaped crystal. Psoriatic arthropathy can present before psoriatic skin lesion. A positive family history of psoriasis may point towards this diagnosis. Pyrexia Still's disease has a characteristic pattern. It typically rises in the late afternoon, early evening in a daily pattern, and accompanies a worsening of joint symptoms and rash. Relapsing polychondritis is a multi-system condition which most commonly causes the relapsing episode of auricular chondritis. Renal complication of systemic sclerosis, that is the sclerodermic renal crisis. Treat the patient with ACE inhibitor. Renal impairment, respiratory symptoms, joint pain, systemic features. Consider the ANCA-associated vasculitis. Salivary gland biopsy or the labial gland biopsy is the most definitive way of confirming the diagnosis of the primary Sjogren syndrome. Section will show typical lymphocytic infiltration. Spinal stenosis is often relieved by sitting down or leaning forward. Start alendronate in patient greater or equal to 75 years following a fragility fracture without waiting for a DEXA scan. The concurrent use of methotrexate and trimethoprim containing antibiotics may cause bone marrow suppression and severe or fatal pancytopenia. The most common cause of death in systemic sclerosis is respiratory involvement, interstitial lung disease, and pulmonary arterial hypertension. The most common cause of death in systemic sclerosis is respiratory involvement, interstitial lung disease, pulmonary arterial hypertension. Urgent admission and administration of corticosteroid is important in giant cell arteritis associated with the visual loss. Anterior ischemic optic neuropathy accounts for majority of the ocular complication in temporal arteritis. A positive pathology test is suggestive of the Behçet syndrome. Methotrexate can cause hepatotoxicity, so we need to monitor the liver function testing. And over 90% of patients with SLE are ANA positive, therefore it's useful to rule out the test. So ANA is the gateway, or ANA is the most sensitive in case of SLE, and anti-dsDNA and anti-Smith, they are the highly specific. So this is also the end of our rheumatology key concepts, and also this is the end of our first session, and inshallah we'll continue the second session at around 5:30 p.m. exactly after 1 hour. So any question?
No, sir. Thank you.
Okay,
And how long you will teach after the break?
How long it will be? I will try to discuss the importance topic that to be read from the Passmedicine textbook, and I also discuss the pictorials or the radiology from there. And if anything is extra needed, I can also use the Google. So probably it may take 1.5 hour or maximum 2 hour. This is my approximate assumption. Yeah, go on.
So it's same subject.
Yeah, same subject, rheumatology. Okay, thank you.
So will we discuss the questions in the next part, is it?
No. We won't discuss the question. I will discuss the theoretical portion, the past medicine textbook portion, and all the radiology given there. And also if we needed extra, I will discuss them using the Radiopedia or the Google. Okay, thank you.
Okay, thank you, sir.
Passmedicine textbook. So the first topic is adhesive capsulitis, which is also known as the frozen shoulder. You need to go through the overview that is most commonly seen in the middle-aged female, and association is with the diabetes. And if we consider the feature, the external rotation is more commonly affected, both in active and passive movement. And always remember the diagnosis would be clinical, no need to go for radiology, no need to go for the laboratory investigation. And the management is supportive in the form of NSAIDs and the physiotherapy. And in some cases, the oral corticosteroid or intra-articular corticosteroid may be needed in the advanced cases. So ANCA-associated vasculitis, typically three conditions, GPA, MPA, as well as the anti-GBM disease and CSS. And all the three conditions, they will come up with the features of RPGN. The CSS does not come up with the features of RPGN. All the three, GPA, MPA, and anti-GBM, they will come up with the features of crescentic GN and features of RPGN, and also the renal-pulmonary syndrome, meaning both renal involvement and pulmonary involvement. And this chart is important. C-ANCA is predominantly associated with GPA, and P-ANCA is predominantly associated with MPA, CSS, and PSC, as well as ulcerative colitis. And the target for C-ANCA is PR3, and for P-ANCA is MPO. Ankylosing spondylitis, this is a 5-star topic. You need to read everything, the information given here, especially the features. The reduced lateral and forward flexion, this is the classical description often given in the question. And the features associated, you can remember using the mnemonic A. And the radiological findings of ankylosing spondylitis, features of sacroiliitis in the initial stages, and later giving rise to the squaring of the lumbar vertebra as well as bamboo spine and syndesmophyte. So this is the advanced ankylosing spondylitis. This is known as the formation of the bamboo spine, and this is the dagger sign. So dagger sign along with formation of the bamboo spine in advanced cases. And this one is squaring of the lumbar vertebra. So in normal cases, it should be concave like this, but when there is squaring, there should be pathological changes in the fragmentation, in the anterior fragmentation. It will look like linear, and the structure, instead of rectangular shape or heart shape, it will look like a square shape. And there should be evidence of subchondral sclerosis, double margin, white color, subchondral sclerosis. So again, squaring of the vertebra, and this is the syndesmophyte formation, ossification of outer layers of annulus fibrosus. Look at the double lining here, the dense lining. This is the syndesmophyte formation. And these are the early stages of bamboo spine. In the advanced cases, it will be like a linear line, giving rise to a dagger sign, which will be seen in advanced cases, known as the bamboo spine. And they are the subchondral sclerosis.
Doctor, can you please show squaring once again?
So look at here, the shape. The shape will look like the square shaped, number one. So the normal one would be absolutely concave. But in case of squaring, it should look like some of the linear pattern. Look at here, the linear shape and looking like the square shape. This is the squaring of the vertebra. So complete linear line.
Yeah, that's great. Thank you very much.
And look at the linear line here, the dagger sign. This is the bamboo spine. Next one is antiphospholipid antibody syndrome. This is commonly associated with the SLE condition. And you need to remember the other features like the venous and arterial thrombosis, as well as this is often related to the recurrent fetal loss. And if a patient with APS comes up with hematuria or loin vein, think of the renal vein thrombosis. And that renal vein thrombosis can further be complicated if the patient has the underlying nephrotic syndrome. And the most commonly antibodies related to this is the anti-cardiolipin antibodies. In some cases, anti-beta-2 glycoprotein 1 or lupus anticoagulant may also be present. Next one is the AVN. The commonest cause is the long-term use of the corticosteroid therapy. And we should go with the MRI is the investigation of choice. So the changes in case of avascular necrosis would be there should be increased bony density. It should be look like the whitish color, and the rounded circular margin. The rounded circular margin, it would be distorted, giving rise to some sort of deformities, or in some cases we can also expect the flattening of the femoral head. There should be also features of osteopenia or pseudo fracture. And always remember the joint space. The joint space would be preserved. In case of AVN, the joint space is reduced only in case of osteoarthritis. So the joint space is preserved here, but there is some sort of flattening of the femoral head. There is also increased bony density, and there is some sort of pseudo fracture as well as the osteopenia. So these are the pseudo fracture or the osteopenia along with increased bony density. And there is also flattening of the femoral head. And the definitive management for avascular necrosis is the joint replacement. Next one is Azathioprine. Go through the overview, adverse effects, as well as the interaction. The Behçet syndrome, this is also a 5-star topic. Go through the epidemiology, especially the Mediterranean origin, comes up with oculo-oral genital manifestation. And this is a cause of aseptic meningitis. Remember, Behçet syndrome causes the aseptic meningitis, not the septic meningitis. Diagnosis is with the pathogen test. And this is associated with HLA-B51. The bone disorders, Lab-Vellus, this has already been discussed. Next one is the bone tumor. Bone tumor isn't important, not the malignant tumor. Charcot's joint. Charcot's joint is the neuropathic joint destruction. It may occur in case of neuropathy secondary to the tertiary syphilis. And usually there should be absence of pain. So look at here, there has been extensive bone remodeling or extensive bony disorientation. And there is also widespread evidence of sclerosis. These are the typical features. The bone remodeling, or there should be derangement in the fragmentation, which is highly suggestive of the Charcot's neuropathic arthropathy. chronic fatigue syndrome. Go through the features and investigation. We need to carry out all the investigation, but usually all of them will come out negative. And management is with the aerobic exercise as well as the CBT. Next one is denosumab. Go through the overview, indication, and its side effect and the mode of action. Dermatomyositis. This is nothing but polymyositis with skin involvement. Go through the skin picture, especially photosensitive rash, heliotrope rash in the periorbital region, Gottron's papilla, and mechanics hand. And mechanics hand means anti-synthetase syndrome may be associated. Investigation to be carried out in dermatomyositis, and management is with the steroid. Next one is the diabetic amyotrophy, and always remember there should be no lumbosacral structural lesion in case of diabetic amyotrophy. Diabetic amyotrophy is usually bilateral, and the microvascular lumbosacral plexopathy, this is usually unilateral. And choice of treatment should be strict control of diabetes followed by the neuropathic drugs like the pregabalin or gabapentin. Next one is Discitis. Discitis is infection of the intervertebral space as well as the vertebral body. The Staph aureus is the most common cause of Discitis, and MRI will have the highest sensitivity. And the MRI on T2 image, it will show the increased signal intensity. So look at here, there is destruction of the vertebral body, and here there is increased signal intensity within the intervertebral space. And normally the signal on the spine, on the anterior, on the posterior portion of the vertebra, it will look like very thin, delicate line. But when this is very much broad or widened, this is known as the increased signal intensity on the MRI, and this is suggestive of Discitis. And also there should be involvement of vertebral body as well as intervertebral space.
Sorry, Dr. Ahad, how do you differentiate, how to diagnose the Discitis? Clinical feature.
The clinical picture, they will comes up with the features of, in most of the cases, they usually comes up with the back pain and as well as fever, and this is usually gradual onset. Okay. Actually, there is no something called the specific pattern. They will comes up with the generalized back pain as well as features of fever coming up with a gradual onset. And for confirmatory diagnosis, we need to go through the MRI, and the MRI will detect the Discitis. In the MRI, we'll get the involvement of the vertebral body, intervertebral space, as well as increased T2 signal intensity. And in some cases, they may also give some clues regarding the infection or something called the epidural abscess.
Okay.
So next one is DLE, cutaneous manifestation of SLE. So is it scarring alopecia or non-scarring?
Scarring.
Yeah, this is the scarring alopecia. What are the causes of scarring alopecia?
Alopecia areata.
Leukemia, diabetes if untreated, and DLE lichen planus.
Alopecia areata is an autoimmune condition. Autoimmune condition won't cause the scarring alopecia. Scarring alopecia is commonly caused by, most commonly, two conditions. One is LP, lichen planus, and discoid lupus erythema, the DLE. And in case of long-standing untreated tinea capitis, and this is the DLE which will cause the scarring alopecia.
Can you please show us a non-scarring alopecia as well so we can compare?
Non-scarring alopecia is the alopecia seen in the male pattern baldness as well as hair fall in the women. So this is the non-scarring. There should be no scar, completely regular bright margin. They are the non-scarring.
And alopecia areata, there's a exclamation mark or something. How do you see that?
Okay, we are coming back. So they are the scarring alopecia. Exclamation mark. Exclamation mark. Yeah, right. So the linear line. So the exclamation look like a linear line. In case of alopecia areata, we will get this type of linear line. This is known as the exclamation mark. What's the diagnosis here?
Drug-induced lupus.
Is it lupus or acne rosacea?
Lupus.
How to differentiate?
Nasolabial fold.
Yeah, exactly. In case
Nasolabial
of lupus, the nasolabial fold would be speared and it will give typical the butterfly appearance. And in case of acne rosacea, there should be involvement of the nasolabial fold, and also will get the features of pustule. In some cases, we'll get the features of pustule or rhinophyma. Drugs causing DLE, features and overview, they are important. Next one is Ehlers-Danlos syndrome. The type 3 is most commonly affected, known as the vascular. And we'll get the features of hypermobile joint and increased skin fragility. And FMD, also known as recurrent polycerositis. Go for the features. Treatment is with the colchicine. Fibromyalgia, typically the females are more commonly affected and there should be widespread pain throughout the body with tender points. And pain would be at multiple points or sometimes they explain as an overspread pain or pain all over the body. And there may be some sort of sleep disturbance or psychiatric problem. Next one is gout. Gout is the first topic. So overview, common site of effect. So synovial fluid analysis, it will show the needle shaped negatively birefringent monosodium urate crystal under the polarized light, and the uric acid level should be elevated, usually greater than 450. And radiological sign, the earliest sign is the joint effusion and punched out lesion. Punched out erosion is highly suggestive of gout. And always remember, in case of rheumatoid arthritis, we will get the features of periarticular or juxtaarticular osteopenia. It should be absent in case of gout, and most commonly it affects the first MTP joint. So they are the punched out lesion. And there is also evidence of sclerosis here. And this punched out lesion is highly suggestive of gout. So here is a punched out lesion. Gout management, we can start with NSAIDs or colchicine. Or in some cases, steroid may be needed. Depending on the contraindication, we will choose the drug for gout. And there are indications for urate lowering therapy, that is the allopurinol or febuxostat. Gout predisposing factors. Most common pathophysiology is due to the decreased excretion of uric acid, which is often due to the diuretics, CKD, or lead toxicity induced. And there is one condition associated with gout known as the Lesch-Nyhan syndrome. And this occurs due to the HGPITS deficiency, and patient will have the neurological deficit as well as learning difficulties. Next one is the hip problems. You can just go through the Perthes disease, nothing else. So the Perthes disease, this is usually bilateral. There should be extensive destruction of the femoral head, as well as destruction of the acetabulum. And this predominantly occurs in the children. So extensive destruction of femoral head as well as the acetabular socket. Knee problems, just the tibial apophysitis. This is important. Langerhans histiocytosis. Here we will also get the punched out lesion. And on electron microscopy, tennis racket shaped barbue granules would be found. So these are the punched out lesion, and the scalloped edge or the bevel shaped edge. Something extended, not linear. Lower back pain, two commonest causes are the spinal stenosis, peripheral arterial disease. And peripheral arterial disease, this is one of the most commonest cause of lower back pain. And this vascular pain may be mimicked by this claudication type of pain due to the spinal stenosis. And spinal stenosis is usually bilateral with gradual onset. And peripheral arterial disease will have the history of the vascular disease, and this is linked to the smoking. And spinal stenosis, this is not linked to the vascular disease or the smoking.
Doctor, can you please mute this Dr. Siddharth Sharma?
Next one is Marfan syndrome, the rheumatological condition associated with the cardiac complication. And all the features are important, especially all the cardiac complication. And there should be upward lens dislocation with low sclerella. And dural ectasia, that is ballooning of the dural sac at the lumbosacral region. This is one of the predominant findings in Marfan syndrome. So this is the dural ectasia. There should be severe circular type of lining or the rounded. Metabolic disease overview features. The MTX overview indication adverse effect, especially features of predominantly lower joint fibrosis as well as the liver fibrosis and pulmonary fibrosis, and monitoring is always with the liver function testing. Osteoarthritis of the hip, risk factors, features, and the radiological findings are very important, especially the reduced joint space. So what should be the radiological findings in osteoarthritis? What get the features of
Subchondral
loss?
cyst.
So loss of joint space, and there may be osteophyte formation as well as subchondral sclerosis and subchondral cyst. So these are the subchondral cyst, cystic structure, blackish structure within the white bony matricles. These are the subchondral sclerosis, whitish shiny with double layered, and joint space narrowing. And this is osteophyte formation. Remember, osteophyte formation always occurs in the lateral portion of the joint. So osteophyte formation, narrowing, irregular double margin, subcondylar sclerosis, tibial spiking may be present in some cases. What is the first line treatment for osteoarthritis?
Paracetamol and topical NSAID.
Yeah, paracetamol plus topical NSAIDs. Second line are the oral NSAIDs with PPI coverage. Next one is osteogenesis imperfecta, which occurs due to the defect in type 1 collagen fiber. And this will also comes up with the blow sclera. Next one is osteomalacia. Osteomalacia is a 5-star topic. Overview: causes, especially the vitamin D deficiency or commonly seen in the vegetarian diet. Features: laboratory findings, X-ray will show the translucent band or features of pseudofracture. Treatment is with the vitamin D and calcium supplementation. Osteomyelitis. What is the commonest organism for osteomyelitis?
Staph aureus,
And if the patient has underlying sickle cell disease,
salmonella infection,
yeah, salmonella infection.
type,
And MRI is the investigation of choice. First line is usually the high dose IV flucloxacillin. Osteopetrosis, also known as marble bone disease, all the laboratory findings would be normal. Normal calcium, normal phosphate, normal ALP, normal parathyroid level. Osteoporosis and fragility fracture. This is 5-star topic. When to go for bisphosphonate, when to go for denosumab. Causes of osteoporosis and other risk factors. And steroid or glucocorticoid are the commonest cause of osteoporosis, and osteoporosis may also occur following the PPI and SSRI. Osteoporosis management guideline key points, these are important. Denosumab is the rank ligand inhibitor given, remember the rule of S for sumab, S for subcutaneous, S for 6-monthly interval. And teriparatide is another alternative to denosumab, but teriparatide is usually given every daily injection, so usually denosumab is preferred over the teriparatide. And if the bisphosphonates are contraindicated and not suitable and denosumab isn't in the option, in that case the teriparatide would be the answer.
Sir, is there a cutoff value for teriparatide also? Because for denosumab and the rank, it's like more than 3.5 and 4
Yeah,
minus.
if the level is less than minus 3.5, then denosumab and teriparatide, these two are indicated. And if both of them are in the option, go for denosumab. If denosumab not in the option, go for teriparatide. And remember, the cutoff value is less than -3.5 in both cases. But it may also be indicated if the T score level is greater than -3.5, that is less than -2.5, and there is still features of fragility fracture or 2 or more osteoporotic fracture despite treating with the bisphosphonate. That is the treatment failure cases.
And sir, what about postmenopausal women? So do we give teriparatide or HRT?
For the postmenopausal women, if they comes with fragility fracture, then we can go for the teriparatide, and the hormonal replacement therapy, they are usually for the prophylaxis. But once the fragility fracture has occurred, we need to go for denosumab or teriparatide.
Okay, thank you.
So features of osteoporosis here. So this is sacral 1, 2, 3, 4, 5, 12, 11. So 10 and 8 is involved here. Parasites of the bone. This is 5-star topic. Outward view, predisposing factors, especially increasing age and male sex. Male patients are more commonly affected by the Paget's disease, but in some cases the female may also be affected.
So can you please show the spinal fracture once again? I think that was pretty quick.
Sorry?
The spinal fracture you just showed, right? Can you show it once again, please?
So this is sacrum, okay? This is sacrum, the
Yep.
lowermost. This is sacrum. So start calculating from the low. So 5, 4, 3, 2, 1. So these are the lumbar. Then start from the 12, 11, 10, 9, 8. So 8 is involved, 10 is involved. Try to calculate from the lower. It would be easier to calculate. So the 8 and 10 thoracic vertebrae is involved here.
I mean, even the shape is quite deformed if you look at the...
Yeah. The shape is absolutely deformed here. There is a severe fracture shown here. This is the normal vertebra. This is also the normal vertebra. But here almost greater than 50 or 60% masses has been lost.
Thank you very much.
So there are some of the markers of bone turnover which may be seen in case of Paget's disease, like procollagen type 1 N-terminal propeptide, serum C telopeptide, urinary N-telopeptide, and urinary hydroxyproline. And for the exam, the urinary hydroxyproline is most important. And we will get the features of mixed lytic and sclerotic lesion. But remember, mixed lytic and sclerotic lesion, they don't usually appear at the early phases. They appear either in the intermediate phases or advanced phases. And bone scan or bone scintigraphy, they will show the increased uptake. So these are the increased uptake. The black indicates the increased uptake. Perthes disease predominantly affects the young patient 4 to 8 years, and this is usually bilateral, and so there will be severe destruction of the femoral head as well as the acetabular socket. And there are stages. This is known as the catarrhal staging. So you can just remember this: stage 3 and 4. Stage 3 would be loss of structural integrity of the femoral head, and stage 4 would be loss of acetabular integrity. Polyarteritis nodosa, medium-sized vasculitis, more commonly seen in the middle isthmium, and this is commonly associated with the hepatitis B virus infection. And the features are important, especially mononeuritis multiplex and the levodoreticularis. So what are these?
Levodoreticularis.
Yeah, these are the
Vasculitis.
levodoreticularis. And look at the beaded appearance here. This type of beaded appearance is highly suggestive of polyarteritis nodosa. Polymyalgia rheumatica. This is also 5-star topic. Patient will comes up with the features of stiffness. Remember, they will comes up with the features of joint stiffness, and there should be raised inflammatory marker. The age of the patient should be greater than 50. ESR should be greater than 50. And choice of treatment is with the low dose steroid. Polymyositis. Polymyositis don't have the dermatological condition, and both polymyositis as well as dermatomyositis, both of them have association with the malignancy, and proximal muscle weakness is more commonly seen, not the distal. There should be significant elevation in the creatinine kinase, and anti-Jo1 antibody may be seen. And choice of treatment is with the steroid, and if no response to steroid, then go for the steroid sparing agent like Azathioprine or the other groups of drug. So Pseudogout is the deposition of the CP crystal, calcium pyrophosphate dihydrate crystal, and there are some of the risk factor as well as features. And chondrocalcinosis or calcification of the linear calcification of the linear calcification of the meniscus as well as articular cartilage. This is pathognomonic for the pseudogout. What is the first line choice of drug for pseudogout?
Acid.
Yeah, go for the NSAIDs. So the joint space would be preserved. There should be calcification of the lemniscus, and it will also look like the triangular shaped. So this is the normal joint in case of pseudogout. There should be calcium pyrophosphate deposition throughout the articular cartilage, giving rise to the formation of pseudogout. The psoriatic arthropathy. Psoriatic arthropathy means the involvement of the most commonly the DIP joint along with the features of skin involvement. That is the psoriasis. There may be nail changes. There may be a psoriatic skin lesion. And the X-ray will show the periostitis. Periostitis is highly suggestive of psoriatic arthropathy, and in advanced cases, it will give rise to the penicillin cup appearance. So this is normal, and this is the penicillin cup appearance. So this is the normal. It is something look like triangular shaped, looking like the fracture. What are these?
Tophi.
They are the
They are belong.
dactylitis. Okay, they are known as the dactylitis. Involvement of the interlink of the fingers. They are the dactylitis, and dactylitis is highly suggestive of the psoriatic arthritis. And here is the skin changes, as well as some sort of nail pitting or nail changes. There is periosteal reaction, and periosteal reaction may be found in case of psoriatic arthropathy. And there is also evidence of joint destruction here. The Rayner's phenomena, primary and secondary, and the causes of Rayner's phenomena, and what are the factors that may be associated with the Rayner's or MCTD. Management is with the calcium channel blockers, the nifedipine. Next one is the reactive arthritis. What is the triad of reactive arthritis?
Urethritis, conjunctivitis, and arthritis.
Yes, urethritis, conjunctivitis, and oligoarthritis. And most commonly, this is seen following the STI. In some cases, it may be seen following the GI illness, that is the dysenteric form. And what is the name of this lesion? Yeah, this is the keratoderma blepharographia. Relapsing polychondritis. This is a severely painful condition. It will affect the ENT, respiratory tract, as well as the joints and the eyes. Which type of nasal deformity is found in relapsing polychondritis?
Saddle shaped.
Yeah, we'll get the saddle nose. And saddle nose is found in GPA or MPA?
GP.
Yes,
Granulomatosis.
granulomatosis. So rheumatoid arthritis complication, commonest complication may be the cardiac complication as well as respiratory complication. And the Feltis syndrome in long-standing rheumatoid arthritis. What is the most common ocular manifestation or extra-articular ocular manifestation?
So keratoconjunctivitis,
Yeah, keratoconjunctivitis, sicca.
episcleritis.
So condition associated with the positive rheumatoid factor includes the Feltis syndrome, around 100%, Sjogren and infective endocarditis, 50-50, SLE 30%, systemic sclerosis 30%, and in general population without any pathology or without any disease, the rheumatoid factor may be found positive. So initial management for rheumatoid arthritis is single DMARD with short course of breathing prednisolone. And previously there were 2 DMARD, but now it has been replaced by a single DMARD. What is the earliest radiological findings in rheumatoid arthritis? Juxta-articular osteopenia. So juxta means across. So juxta-articular means across the articular surface. We'll get the juxta-articular osteopenia. This is the earliest pathognomonic radiological findings in rheumatoid arthritis. And always remember, rheumatoid arthritis will spare the DIP joint. The PIP and MCP joint is more commonly involved. So periarticular osteopenia, and this is juxta-articular osteopenia. Septic arthritis pathophysiology specially caused by the Staph aureus. First line choice of management is the IV flucloxacillin. Shoulder problem, adhesive capsulitis or frozen shoulder. Sjogren's syndrome, overview, features, investigation. Management is artificial saliva or tear, and pilocarpine may be given. Still's disease, features, management, stepwise management, and the Yamaguchi criteria. SLE is also FABSTAR topics. There should be multi-system involvement, skin, musculoskeletal, cardiovascular, respiratory, renal, neuropsychiatric. SLE investigation, ANA is the gateway. It will carry the highest sensitivity, and anti-Smith and anti-TSDNA, they are the highly specific. Hydroxychloroquine is the first line. If there is renal involvement, this is known as the lupus nephritis. What is the initial choice of drug for lupus?
ACE inhibitors or mycophenolate.
Yeah, we should go with the mycophenolate mofetil. And in case of life-threatening cases, or if there is any features of RPGN, go for the cyclophosphamide. Systemic sclerosis, limited cutaneous, will get the features of CREST. CREST means calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactylian telangiectasia, which is associated with the anti-centromere antibody. Antifuse cutaneous with anti-SCL70, and there should be significant respiratory involvement as well as cardiac involvement. So the shiny skin, and there is evidence of the butterfly rash. Temporal arteritis, or also the giant cell arteritis, features. What is the treatment for temporal arteritis?
Prednisolone, 60 mg, If it is with a visual loss, then it is 500 to 1000 mg, 1 gram IV prednisolone.
Yeah, in case of uncomplicated case, or if the case is already established visual loss, then go for 60 milligram prednisolone. If this is complicated with history of transient visual loss, then go for IV methylprednisolone. And if no response to the steroid, then go for the MTX, methotrexate.
Sir, did you say we go if there is a renal disease in SLE, we go for mycophenolate?
Yeah,
So
for
when do we go for cyclophosphamide?
For mild to moderate renal nephritis, we should start the treatment with mycophenolate mofetil. If there is good response, continue with the mycophenolate. If there is not adequate response, then either switch on to cyclophosphamide or start cyclophosphamide along with mycophenolate. And if there is severe lupus nephritis or any features of life-threatening lupus nephritis or features of RPGN, then start directly with the cyclophosphamide. No need to go for the mycophenolate. So in short, mild to moderate, start with mycophenolate. Life-threatening case, RPGN features, go for cyclophosphamide.
Okay. Do we need to remember the dose or anything?
No need to remember the doses. Only you can remember the name of the drugs. So upper limb anatomy, and you can just give a brief reading. They are more commonly encountered in the part 1 exam, and you can just remember the lobe muscles. So we have completed in a brief manner. So any further question from anyone?
Do we need to do these nerve roots, because there are questions in past test and past medicine about the nerve roots?
Nerve roots, they usually come in the part 1, but if you have studied them very well in part 1, you can revise them. But if someone has skipped in the part 1, then they may also skip for part 2. This is based on individual. Okay, anyone, anything else? Then I think we can conclude here today, and inshallah we'll continue tomorrow with the nephrology. Okay, thank you everyone.
Thank you, sir.